Hello friends and faculties. With regards, I am Dr. Ashish Agarwal. Today I have given the opportunity to present thoracic anatomy. I shall start my presentation. When we discussing about the anatomy, we must pay our tributes to this legendary man Andre Vesalius. This man has done dissection of the human bodies and artistic diagram with himself, and for printing in that era he himself made the exact wooden blocks for printers also. And the unfortunately this man has given the term plagiarism, and for 200 years, approximate 2 centuries, his book The Human Corporis Fabrica has been plagiarized so many times, but this man never given has a recognition during his lifetime. So let we start with the anatomy discussion with the tribute to Andre Vesalius. During this presentation, I will discuss these topics briefly: chest wall, pleura, trachea and bronchi, bronchopulmonary segments, diaphragm, intercostal space. And rest of the topics will be discussed later on by senior faculties of the team. In the chest wall, I focus mainly on these 6 principal muscles which used for reconstruction of chest wall defects and protection of bronchial stumps or filling of the cavity post pneumonectomy. In these 6 muscles, the latissimus dorsi muscle is the very important muscle. It is the most common and the largest muscle which is used for the reconstruction purposes, and this muscle has the advantage of wide arc of rotation. It originates from the T6 to S3 posterior crest of the ilium and insert intratubular groove of the humerus. It has a blood supply from thoracodorsal nerve artery and artery to the serratus anterior and drained by the similar fashion. The second muscle is the pectoralis major muscle, which is used for the anterior chest wall defects, mainly in cases of sternal dehiscence. It has been used for as a pectoralis major flap to cover the defect of the sternum. This muscle has the origin from the sternum, clavicle, ribs 1 to 7 and inserts at the tricipital groove of the humerus and has a blood supply from thoracoacromial vessels and secondary blood supply from the internal mammary and intercostal artery. The third muscle in this is rectus abdominis muscle, which is used for lower anterior half of the chest wall defects. It has a vertical and horizontal orientation for its application, and the vertical application of this muscle is more safe because it preserves more of its collateral supply. It originates from the pubic crest and inserts at the rib cartilages of 5th, 6th, 7th and xiphoid process, and has a blood supply from superior and inferior epigastric arteries. The next muscle is serratus anterior muscle, which is also known as workhorse of endothoracic surgery. This muscle is used for buffering of the between trachea and esophagus in cases of tracheoesophageal fistula, and used for mainly bronchial stumps covering. The serratus anterior muscle has a origin from outer surface and superior border of the ribs of 8th, 9th, 10th and intercostal fascia and inserts at the scapular tip. It has a blood supply from serratus branch of thoracodorsal artery and long thoracic artery. The rest of the 2 muscle, external oblique and trapezius muscle, are the less commonly used muscles. External oblique originate from the external surface and inferior border of the ribs 4 to 12, inserts over iliac crest and lower abdominal processes, and has a blood supply from lower interthoracic intercostal vessels. And the trapezius muscle has a origin from occipital bone C7 T12 spinous process and inserts over posterior and lateral third of clavicle, acromion, superior lip of scapular spine, and has a blood supply from transverse cervical artery and occipital branches and intercostal perforators. And the trapezius muscle is the second muscle which can be used as a buffer between the esophagus and trachea for the TO fistula surgery. The visceral the pleura is basically a monolayer of mesothelial cells on basement membrane, which protects lungs from the frictional trauma of the chest wall and diaphragm during respiration and allows smooth expansion of the lungs. The visceral pleura covers lung from hilum outward and lines major and minor fissures. Parietal pleura lines inner surface of chest wall, mediastinum and diaphragm. The pleural extension is superiorly goes about 2 to 3 centimeter above the first rib and forms the dome of lung, and inferiorly extended as follows the inferior extension follows the diaphragm attachment to chest wall. Anteriorly ends at 6th or 7th rib and courses obliquely. Laterally it extended at a mid-clavicular line over the 8th rib, mid-axillary line over the 10th rib, and lateral border of erector spinae muscle over the 12th rib. About the blood supply of bronchial artery, McLaughlin has suggested that visceral pleura has a dual blood supply from pulmonary artery and the bronchial artery, but majority of blood supply comes from the bronchial artery, while the parietal pleura receives blood supply from the areas where it covers on from the systemic arteries. When we are discussing about the pleura, there is a special mention I am giving stress on the pleural recesses of the anterior costo-mediastinal. There are 4 pleural recesses: anterior costo-mediastinal, posterior costo-mediastinal, costophrenic and mediastinophrenic. These recesses are the junction between the different segments of parietal pleura reflection. Here I am emphasis giving you on the anterior costo-mediastinal recesses, because the configuration of anterior costo-mediastinal left and right in such a way that they forms 2 triangles pointing each other and left pleural recess, left costo-mediastinal, anterior costo-mediastinal pleural recess goes 3 centimeter away from the midline and obliquely comes down to the comes down, and this narrow space between these 2 pleural spaces gives or makes possible to access anterior mediastinum via median sternotomy without opening of the pleural cavity. The next, bronchopulmonary segments. This bronchopulmonary segment most accepted classification was given by Jackson and Huber in 1943, while in the 6th edition of the Nomina and Anatomica replaced apical word with the superior and lateral word used for the middle basal lobe, and ventral and dorsal basal lobes replaced with the terms anterior and posterior. So basically we have 10 lobes in the 10 segments in the right lung, 3 lobes 10 segments in the right lung, and 2 lobes and 8 segments in the left lung. The right upper lobe bronchus has 3 segments, apical, posterior and anterior. Middle lobe bronchus has 2 segments, lateral and medial, and the right lower lobe segment has 5 segments, superior, medial basal, anterior basal, lateral basal and posterior basal. On the left side, left upper lobe has 4 segments, apical, posterior, anterior, superior lingula, inferior lingula, and left lower lobe has 4 segments, superior, anteromedial basal, lateral basal and posterior basal. The bronchopulmonary segments, first described by William Ewart in 1889, this is a unit which have its own bronchus, pulmonary arterial, venous and lymphatic system. These segments are constant with their in topographic position, and we can remove one segment without disturbing the function of the adjacent segment. So these segments are pyramidal in shape, surrounded by connective tissue septas. Segmental bronchus runs down the center of the segment. Corresponding branch of the pulmonary artery lies on the posterior surface of the segmental bronchus. Pulmonary veins run runs in intersegmental plane and marks boundaries of the individual segments. Now the fissures, this fissures, we know that right side we have two fissures, oblique and horizontal, left side only oblique fissure. These fissures called complete when lobes only held together at hilum by bronchus and pulmonary vessels, and incomplete when areas of parenchymal fusion between the lobes present. 25% of the times oblique fissure is incomplete and 60 to 70% of the time horizontal fissure is incomplete. Oblique fissure is a major fissure of the left lung. It separates upper from the lower lobe, extends from T3 posteriorly to the 6th costochondral junction anteriorly, is more vertical than compared to the right oblique fissure. On the right lung, oblique fissure separates upper and middle lobe from lower lobe, extends from T4 posteriorly to 6th costochondral junction anteriorly, and is more obliquely compared to the left side. Horizontal fissure of the right lung separates upper and middle lobes, extends from oblique fissure in the mid-axillary line to the level of the 4th intercostal cartilage, and is, as I told, is often incomplete. Diaphragm is a dome-shaped structure which separates thoracic and abdominal cavity. It has a function of chest cavity expansion during inspiration and maintain the occlusion of lower GE junction during inspiration to prevent reflux from stomach into the esophagus. It is a musculotendinous structure. Central part forms of central aponeurosis, which is a clover leaf-like structure, has one anterior and two lateral leaves. The muscular part has three portions: sternal portion, costal portion, and the lumbar portion, in which sternal portion is the smallest portion, which extends between tendon to rectus sheath and xiphoid process. The costal portion is lateral to the sternal part on either side and attaches to the rib, and the lumbar portion on either side of the vertebral column forms right and left crura. The gap between the costal and the lumbar part, known as Bocaldeck's gap. The diaphragm has a rich blood supply. Inferior surface has a blood supply from the inferior phrenic artery, which is a branch of aorta, and the superior surface has a blood supply from pericardiophrenic artery and musculophrenic artery, branches of the internal memory artery. The openings of the diaphragm, these are basically gaps between the muscular part or the central tendon part, which is allows structures to pass through the abdominal cavity to the thoracic or thoracic cavity to the abdominal cavity. It is very important because it is most often asked short note question and most often asked MCQ question about the structures passing through the gaps. Between the costal portion and the sternal portion of the diaphragm, muscular portion of the diaphragm, there are two gaps. On the right side, it is called as trigonum sternocostal dextrum, also known as Morgagnic space, and on the left side, it is known as Larry's gap. On both the side, the content is same: superior epigastric artery and vein. The third the third space is vena cava foramen at the level of thoracic vertebra 8, allows passage of IVC and the right phrenic nerve, and at the level of T10, thoracic vertebra 10, the esophageal hiatus, which allows passage of the esophagus, anterior and posterior vagal trunk. In the formation of this esophageal hiatus, muscle of flow and transverse intertendinous muscle plays an important role, because these two muscle has a scissor effect that works to close the lower end of the esophagus during inspiration. And at the T12 level, there is aortic hiatus, which allows passage of aorta, aortic plexus and ductus thoracicus. Now the other openings are aperture in medial crus, which allows passage of lesser splanchnic nerve, medial lumbar cleft, which is allows passage of greater sphincteric nerve, azygous and hemiazygous vein, and lateral lumbar cleft, which allows passage of truncus sympatheticus. Now the intercostal space, 12 ribs forms 11 intercostal space. In this intercostal space there are three muscles: external intercostal muscle, internal intercostal muscle, and innermost intercostal muscle. 11 external intercostal muscle, 11 pairs on each side. Fibers run obliquely, inferiorly and anteriorly from rib above to rib below, are replaced by external intercostal membrane between costal cartilages anteriorly, and its function has elevation of the ribs during respiration. Internal intercostal muscle, 11 pairs on each side. Fibers run at right angles to those of the external intercostal muscle inferiorly and posteriorly, replaced by internal intercostal membrane posteriorly, and its function has lower down the ribs during respiration. Innermost intercostal muscle is most often incomplete and variable. Fiber runs in a direction similar to those of internal intercostal muscles, are separated from internal intercostal muscle by intercostal nerve and vessels. Subcostalis muscle or infracostal muscle, it is a thin muscular slabs that are variable in size and shape and well developed only in lower part of the thorax. In this neurovascular bundle, their arrangement is most capillate, intercostal vein, mid position is artery, and the most caudal is the intercostal nerve. In each space there are two sets of arteries, anterior and posterior intercostal arteries, which anastomose with each other, and posterior intercostal artery originates from descending thoracic aorta, except first two intercostal space where it originates from the superior intercostal artery branch of the costocervical trunk. And in each space there are two anterior intercostal arteries per side per space above and below each rib. Upper 6 spaces gets branch from the IMA, and in lower 3 spaces branch of IMA musculophrenic artery gives the anterior intercostal artery branches. Trachea and bronchus. Trachea is a conduit for ventilation and secretion clearance. Configuration of trachea is more circular in children and oval shape in adults. Trachea extends from lower border of cricoid cartilage to the level of the carina. It is a C-shaped cartilaginous ring from anterior and lateral wall. External diameter of trachea, coronal diameter 23 mm in male and 20 mm in female, and sagittal diameter is 18 mm in male and 14 mm in female. It normally ranges length from 10 to 13 cm. It has 2 rings per centimeter of trachea. Each ring averages 4 mm and makes approximate total 18 to 22 rings, and the tracheal wall thickness is 3 mm. It divides in the right and left mainstem bronchus. Right mainstem bronchus is more vertical and left mainstem bronchus is more horizontal in orientation, and left mainstem bronchus is longer than the right one. Blood supply of trachea, it is very important. It enters from the lateral wall of the trachea in a segmental fashion throughout its length, and it's a very important surgical concept, surgical principle to avoid excessive devasculation of the trachea. The carina and lower half of the trachea gets supply from bronchial arteries, superior, middle and inferior bronchial arteries. Anterior branch of superior bronchial artery supplies the left mainstem bronchus and anterior carina. Posterior branch of the superior bronchial artery travel behind esophagus to supply right mainstem bronchus. Inferior bronchial artery supplies mainly left mainstem bronchus, and the middle bronchial artery anastomoses with the superior bronchial artery and supplies the carina. On the upper half of the trachea, cervical trachea, it gets blood supply from inferior thyroid artery, lower, middle and upper tracheoesophageal branches of the inferior thyroid artery, which supplies their respective sections. Superior thyroid artery doesn't directly supply the trachea, but indirectly it supplies anastomoses with the inferior thyroid artery or contribute via small branches from the isthmus of the thyroid. Segmental arteries branches superiorly and inferiorly over the width of the tracheal ring and forms a series of longitudinal anastomosis along the lateral wall. It further bifurcates into anterior and posterior intercartilaginous arteries when it enters in the tracheal intercartilaginous space. Anterior intercartilaginous arteries anastomose contralateral counterpart and posterior one anastomosis with the primary esophageal arteries. This segmental arrangement limits the circumferential dissection of the trachea. Thank you.